Hello, and welcome to the 2018 National Center for Medical Home Implementation e-learning series, where the rubber meets the road, conversations about innovative and promising practices in pediatric medical home implementation. My name is Joanne Jung. I'm a pediatrician at Asian Health Services, a federally qualified health center in Oakland, California, and a member of the Project Advisory Committee for the National Center on Medical Home Implementation. This is the second episode in a two-part learning series brought to you by the National Center for Medical Home Implementation, or National Center, at the American Academy of Pediatrics. We will be referring to the National Center for Medical Home Implementation as the National Center throughout this episode. The National Center is a cooperative agreement between the Maternal Child Health Bureau of the Health Resources Services Administration and the AAP. The goal of the National Center is to ensure that all children and youth, particularly those with special health care needs, have access to a medical home. Before we begin, I want to provide some context about this e-learning series. Since 2014, the National Center has hosted an annual webinar series focusing on various components of pediatric medical home implementation. This year, it was decided that rather than hosting a webinar series, a unique and more conversational approach would be taken to share information from an initiative that's been underway for several years via the National Center. We're calling it an e-learning series. The initiative that provides the foundation for this program is the Innovative and Promising Practices Initiative. This initiative features programs that provide examples of evidence-informed strategies that can be replicated across diverse settings. An archive of the featured programs is housed at the National Center website. The practices to be showcased were selected through a rigorous review process conducted by the National Center, staff, and leadership from the National Center's Project Advisory Committee. The 4 practices featured during this e-learning series will provide diverse and insightful perspectives on pediatric medical home implementation. We're looking forward to learning from their experiences and their expertise. The theme for today's episode is tools and strategies to advance the pediatric medical home by developing partnerships at the clinic, community, and systems levels. By the end of the series, you will be able to do the following. Describe innovative strategies to implement the 7 components of pediatric medical home implementation at the clinical, organizational, and systems levels. Discuss strategies to engage with state maternal child health, Title V, children and youth with special health care needs, programs, and others in the provision of family-centered care. Provide evidence-informed examples of pediatric medical home implementation strategies and identify tools for assessing, implementing, and measuring pediatric medical home. Today, our conversation will provide the featured practices an opportunity to share an overview of their initiative with you. They will also discuss implementation strategies and lessons learned. Towards the end of each episode, we'll share a list of resources discussed during the conversations, as well as additional resources that can support participants in medical home implementation. I'd now like to begin the episode by asking our speakers to introduce themselves and to provide an overview of their respective projects. Can you please introduce yourself, describe your practice, as well as some of the innovative features that you've been able to implement? Diane, would you like to begin?
Sure. Wise Pediatric Care is a solo pediatrician independent practice serving about 1,800 patients in Sarasota, Florida. Our patients are predominantly privately insured. About 10% of our children are insured through Medicaid. We are a team comprised of 1 pediatrician, 2 part-time nurse practitioners, 2 full-time LPNs and 1 part-time LPN, a front office coordinator, a therapy dog named Elliot, and me. I'm the practice manager, but first and foremost, I am our parenting, child development, and pediatric sleep specialist, as well as our resource coordinator. Just like me, everyone on our team wears multiple hats. Our nurses are also certified breastfeeding counselors. One serves as our new patient coordinator, another as our asthma care coordinator, another as our vaccine manager. Our front office coordinator also serves as our manager of our well visit recalls. Our patient-centered medical home journey began in 2013 when we opened our doors as a new practice with a goal to create what I like to call back to the future care for children, including those children with special health care needs, a place where physicians actually had time, along with the care team, to build relationships with patients and their families, where there would be a focus on the whole child, social, emotional, behavioral, developmental, as well as physical health and well-being. a place where families would have access to care and information, education, and support whenever they needed it. Although we didn't have the words to name it or the tools to create it, it turns out we were aiming to build a patient-centered medical home. We needed a roadmap, and we found that first through the National Center for Medical Home Implementation, and then through the Florida Pediatric Medical Home Demonstration Project, an 18-month initiative through the AAP, the American Academy of Pediatrics. More recently, we were able to achieve Level 3 NCQA Patient-Centered Medical Home Recognition with critical technical and financial assistance from the Practice Transformation Network, a primary care collaborative funded through CMS. All this to say that small independent practices need not be limited by their size or their resources. There are amazing opportunities for support available to help us align our work with the highest standards of care. Some of what I see as the most innovative features of our patient-centered medical home are actually ones that are often assumed but not strategically tended, and yet are foundational to the work that we do and critical to creating and sustaining effective partnerships across all stakeholders, staff, families, community partners. First, we're committed to a team approach. We are not a top-down leadership organization. Team members' input is expected, solicited, and valued. There are no low-status or high-status positions in our practice, and we have specific strategies in place to ensure that this culture of team is sustained. Second, we are relationship and strength-based. We focus on and devote training time to ensuring that all staff have the skills it takes to build and maintain collaborative, supportive relationships within our team and with our patients, our families, and our community partners. This isn't a one-and-done activity. These skills require consistent modeling, practicing, assessing, and perfecting. Third, we are family-centered, which means that patient and family input shapes much of what we do within the context of individual patient visits and with regard to our entire overall service delivery. And finally, we cultivate and depend upon strong community partnerships to provide wraparound services for our children that as a small practice we could never support under one roof.
Thank you so much, Diane, for describing all the wonderful features of Weiss Pediatrics and what you've been able to accomplish in really resourceful ways. Marion, can you please introduce yourself now and describe an overview of your project that you've been doing in North Carolina?
Sure. So my name is Marion Earls. I'm a developmental and behavioral pediatrician and a general pediatrician. I've been practicing in North Carolina for, a little over 30 years, and my current position is that I'm the Director of Pediatric Programs for Community Care of North Carolina. We are the delivery arm for Medicaid across the state. We involve greater than 95% of the primary care clinicians that are in the state, and we have regional networks all over the state. And I just say that so I can put some of this in context. So Fostering Health North Carolina really began as an idea in the North Carolina Pediatric Society, our AAP chapter, in 2008 when I actually was chapter president. But we've been able in more recent years, in the last 5 years actually, to develop this systems-based program to assure medical homes for children and youth in foster care. We essentially really wanted to be able to fully implement the AAP guidelines for kids in foster care and their medical homes. That involves, an enhanced visit schedule and more comprehensive assessments since these are kids with special health care needs. This project has been a cross-sector project. Our major partners have been this Community Care North Carolina, this organization of primary care practices, the North Carolina Pediatric Society, and our child welfare agency, the Department of Social Services. We also have a state advisory group that participates in this, and then we have lots of partners there, including youth who have graduated out of foster care, foster parents, and other groups from around the state that provide care locally for kids in foster care. Our key partner, of course, is the AAP chapter, because our North Carolina Pediatric Society really does the work around policy development at the state and best practices, and they actually have a whole website about our project with all of our best practices. the core of this is this kind of regional three-legged stool. So in each region, the care managers who are associated with one of our regional CCNC network, the pharmacists who are located there, the early childhood care managers are all very involved in this project, along with the practices of the medical homes. And it also includes the local child welfare agency of the local DSS. So it's got a lot of moving parts, and for us it's been very important to do this in a systemic way.
Thank you so much, Marian, for describing your innovative program and just pulling together this cross-sector collaboration across multiple disciplines and actually multiple regions as well. And that is the theme for today. As you know, a medical home is not a building or a place. It includes relationships and experiences outside the clinical setting. So care within this model, as you both described, should be accessible, family-centered, continuous, comprehensive, coordinated, compassionate, and culturally effective. The medical home model includes building partnerships with clinical specialists, with families, as you've described, as well as with community resources. Now, both of your practices have diverse partnerships at the clinic, community, and systems levels. Can you please discuss how you actually built these partnerships and how you're sustaining them? Marian, would you like to begin?
Sure. For anyone who's been very interested in taking care of children who are in foster care, you realize that to provide a medical home for a child or adolescent in foster care, there are many challenges, particularly around several of these components of medical home. It's very difficult to provide continuity, to coordinate care, to be comprehensive, and to be family-centered, correct? So very often you're trying to be the medical home for a child who might be reunified with their family, but you may not have contact with the family. You may have only contact with the foster family. So there's really significant challenges to providing a medical home. And what we realized was that for a practice to do this alone would be a huge heavy lift locally to try to, work with your local child welfare system and get them to understand what it means to be a medical home. All of that work would be extremely difficult for a practice to do by itself. So the cross-sector work of this was essential, and I think to your point, in building these partnerships, it's really relationship building, and there's a lot of maintenance to it. So we have statewide partners, and then we have local partners. So the people at the practices, the people in the medical home, have a relationship with care managers that are part of the network. The care managers really make that connection. They have connection with their local DSS to get information about children who are coming into care. At the state level, we absolutely needed to kind of smooth that for the primary care practices. So we work on enlisting the chapter, the AAP chapter, and the state DSS to support us with this. And I think one of the keys to keeping that partnership going is that you identify benefits on both sides. So we really needed to help DSS and the workers there understand how this will benefit them as well as benefit the kids in foster care in order to have that buy-in. We had to be very inclusive of stakeholders, make sure that we were including and hearing from foster parents and hearing from kids who've been in foster care and the older kids who have finished being in foster care. We needed to develop a common language and understand each other because for DSS workers, they didn't necessarily understand what we meant by a comprehensive visit in a pediatric practice. So we really needed, and we didn't understand their requirements, so we needed to speak each other's language, and that's ongoing. So there's been a tremendous amount of training of folks, training folks in child welfare and foster parents about the principles of fostering health and the principles from the AAP, and also training the primary clinicians about what are the workings of child welfare and how do you negotiate all of the legal pieces and so on. The thing that's been key for us is that we developed standardized ways of communicating with each other, and set up systems where there's a contact person and you can make that connection. And we've also developed standardized forms. So when the clinician knows what to expect when they see the child for an initial visit and when they see them for a comprehensive visit. Another particular challenge around these partnerships is partnering with folks who provide mental health services for children, particularly young children, because of the fact that very often people are siloed. And by definition, kids in foster care are coming with many major psychosocial stressors. So we know that that's been something that we really had to build that communication for. So I guess it's all about relationships, and it's maintaining those relationships.
Wonderful. Thank you so much, Marian, for sharing your insights about what it takes to build relationships in order to counter the fragmentation that so easily takes over the life of a foster child, and to overcome the natural sort of siloed, fragmented service systems that are supposed to be there to serve them. Diane, let's turn the conversation back to Weiss Pediatrics. How did your practice build partnerships within your clinic, with your families, and out in the community?
Well, having strong team partnerships for us means that everyone will have their eye on the same objective, getting to know each child and each family, building positive, engaging relationships, and making sure that all needs are addressed. We build and maintain those team partnerships in a variety of ways. We have monthly team meetings that focus on successes and opportunities for improvement, while also providing professional development on clinical and non-clinical issues so every team member, regardless of their primary role, are familiar with best practices and up-to-date research. In the past, we've had an international motivational speaker work with our team around positive communication skills, and a child psychiatrist who worked with us around how to deal with difficult parents. A community agency representative discussed infant and early childhood mental health and how we can help our families navigate the oftentimes cumbersome agency system, and a child development specialist who discussed strategies for creating successful visits for children with autism. We have team huddles at the beginning of the day and following lunch, and I think our staff would say that this is one of the most effective ways to create and sustain team partnerships, while also ensuring that we're prepared to meet the individual needs of each child scheduled to be seen. Our entire staff participates in huddles to ensure we're sharing clinical and non-clinical information. So, for example, we might make a note to follow up on certain labs, or that a patient has new insurance, or last time this mom was in, she had specific concerns about her baby's growth, so we'll want to follow up with her on that and allow extra time. It's an opportunity to holistically consider every child and family's needs. Strong partnerships with parents means that families trust that we're listening and responsive to their needs, which in turn translates into greater compliance with treatment plans, increased satisfaction, and better health outcomes. Partnerships with families depend upon a willingness to include them in open, interactive conversations. We've convened a virtual advisory group by emailing a diverse group of parents both within our patient population and in the broader community, and we asked them what was important to them when it comes to pediatric care for their children, and then we used their input to construct our model. We now have a family advisory council that provides candid and helpful feedback. The council is led by a parent volunteer and addresses topics such as how best to respond to parents' concerns about resistance to flu or HPV vaccines, what are distinguishing features of Weiss Pediatric Care, and what are the elements of a patient-centered medical home, and how should we prioritize our efforts. Currently, we're convening a subset of the advisory council to focus specifically on our asthma care program. Strong partnerships with community agencies and specialists mean that we have ready access to services for our children and ongoing professional development for our team. Because comprehensive care for all children, and especially those with special health care needs, require services beyond what we could provide under our roof, we rely on developing and sustaining strong partnerships with a large contingent of specialists, both medical and non-medical, to provide those services. As our resource coordinator, I maintain an extensive resource list of partners from diverse disciplines, such as mental health, OT, PT, speech and language, education, child advocates, even early childhood programs. The resource list identifies professionals within each discipline, their location, insurances accepted, areas of specialization, and sometimes most important, parent and patient feedback. And because our team knows our children so well, we're able to recommend specialists that appear to be a good fit for each child and family's unique needs. Sometimes we only get one chance to get that fit right before a parent will give up. So getting it right the first time really matters.
Well, I'm really impressed by that level of personal knowledge that allows you to create that fit. What also impresses me is creating the structures to allow that relationship tending to continue. And one of the features that also stood out was inviting community partners as well as different kinds of specialists into your monthly meetings so that people get to know each other and they get to know the services that are out there. I think these are wonderful and replicable ideas. I have some follow-up questions for both of you. And one of them is, how do you incentivize this kind of partnership with different stakeholders? And I want to start, Marion, with you, because you're talking about cross-sector collaboration of people who normally are very happy to operate inside their silos. How did you incentivize these guys to talk to each other and to keep on working together? And Diane, I think you could probably speak to something very similarly. Silos also exist out in the community, and people are very busy. How do you incentivize people to take the time and the effort to build these relationships, to build this network, and to collaborate in an ongoing way? Marion, let's start with you.
Okay. Well, I will say that it's incentivizing is a endless source of work, right? So you have to keep doing it all the time. I think there were several things that made it right for us when we started to do this. The state was really concerned with their data and how well things were going for kids. Practices were frustrated with how it went for them when the child was brought to them and they had no information and they were expected to do an assessment on a child with no records, that sort of thing. So I think people were really incentivized to make things go better. And it was almost like identifying people's pain point and then offering a system that might actually make that go more smoothly for them. So for a practice involved with fostering health where we've gotten their local DSS on board and so on, it makes their life simpler. So I think that's been a big piece of incentivizing folks. And I think in truth, even though people get mired in their silos around this when you're doing this cross-sector work, I think the people who are doing it for the most part really want to do a better job. And they, sometimes, particularly in bureaucracies, there's so much that mires them in requirements, you kind of lose sight, you lose the forest for the trees, essentially. So I think our way of incentivizing people was to say we were going to make this go better if we can do this together. But I'm not minimizing the fact that you need to keep reminding people of that and inviting them to be part of the dialogue and talk about it and continue to improve it. There's not a way out of the hard work part of it, I think.
Thank you so much, Marion, for that really practical bit of advice of finding the pain points and then helping them to create the solution together as being a major incentive for people to put the work into collaboration and to continue with the reminders, because you're right, things do drop off the radar. Diane, let's turn the conversation back to you. How did you motivate partnership with so many different collaborators and other agencies?
It's interesting to talk about motivating or incentivizing. When it comes to our relationships, whether it's with team members internally or with our community partners externally, everything happens within the context of relationships. So more than incentivizing, we focus on building those relationships. It's inviting people into our medical home here to get to know us. I call it dating. We're kind of dating our partners here, getting to know them, and then identifying our common services where we overlap. More often than not, our partners want to be working with practices like ours where we don't just hand off a child and say, have at it and take care of everything. We're asking to be part of the circle and make sure that the conversation continues once those children go on to one of our specialists. And I find our collaborators are really anxious to do that. It takes picking up the phone and talking to them. It takes constantly making sure that we're asking for each other's feedback and focusing one at a time on our children. We're very lucky in that we're a microcosm of this medical home model, and I think building relationships one-on-one the way we get to do tends not to be that hard as long as you're ready, willing to nurture them.
That's wonderful. I'm struck by both of you in terms of having to put in the work that's involved in building and maintaining relationships and in communicating well and in including people, and that this is really the heart of the partnerships that are also at the heart of the medical home. So I want to turn our conversation next to another feature of high-quality medical homes beyond the partnerships that we've been talking about here. And this other component is the use of data or qualitative feedback in order to improve your programs and services. Assessment and evaluation of activities in pediatric clinics and practices is really important for providing insight on areas of practice strengths as well as areas of improvement. Data can also be used to show how much parents and community members value your program and to help gain the buy-in of stakeholders, leaders, payers, especially for some of the more innovative features that you've been able to institute. So let's discuss the tools or strategies that your practice used for assessment and evaluation of some of these activities you've been describing. Marion, would you like to begin?
You know, it's such a hugely important piece, and you know, whether you're a practice or whether you're trying to do a systematic piece here, to keep people motivated, one thing that keeps people motivated is the ability to give them data and see how things are going. So we had to be very data-driven on this because our partners really wanted data. So at the level of the medical home, what we've done is try to look at indicators of whether kids are getting the services that we would like them to get. So we've been looking at things like well visit rates for this group, for these kids, whether or not they've gotten their developmental and behavioral screening, whether adolescents have gotten depression screening, how are immunizations going, and are we connecting these kids with dental home, because that's often a place where kids in foster care do not have good care. So what we've seen is that being able to use claims data from across the state, that consistently the kids who are in our fostering health system have higher rates in all of those areas, higher rates of well visits, getting connected with a dental home. And so we can feed that back to the medical homes, again, to sort of encourage them, hey, you're really doing a good job. But we can also share that with our partners at Child Welfare. To really show people that, hey, this is making a difference. This collaborative work that we're doing has really been worth it. At the systems level, we are trying to look at how we're doing in terms of these partnerships. So we have 100 counties in North Carolina, which means we have 100 local DSS. And at this point, we're up to about 65 of them that are very engaged and are working with our practices very intentionally. And we're striving towards that all 100 county goal. And so we actually track how many practices and how many DSS are involved with us, and we look at whether we are getting these kids who come into foster care enrolled in this program rather than enrolled in just general Medicaid. And happily, we've been able to increase that from, when we first started a few years ago, only 30% of kids were getting enrolled with our medical homes, and now 88% of them are. So we're, those kinds of things, I can't emphasize how much it's been important to us to get continued support financially and support from folks being involved with doing this. So our state Department of Health and Human Services has identified this population and this project as a priority for the state. So we're quite pleased.
Wonderful, Marion. Thanks so much for describing how your group has been able to use data not only to improve quality, but also to gather support and to motivate ongoing involvement with your initiative. Diane, can you please describe how a smaller practice like yours is able to gather and use data, or maybe like qualitative feedback from families for quality improvement and for sustainability?
Sure. Of course, we track our clinical measures using our electronic health record system and the reports we're able to generate from that, and through HEDIS reports that we get from our Medicaid payers. But as for patient and family feedback, as it pertains specifically to partnerships, high-tech strategies are cost-prohibitive and often not as valuable as a simple questionnaire or a personal conversation. During our Get Acquainted and our prenatal visits with prospective parents, we always tell them we encourage and depend upon patient feedback. And we collect that feedback via a suggestion box in our waiting room, satisfaction surveys at checkout, and one-on-one conversations. I call every patient, every parent who transfers out of our practice to ask what we could do better going forward for other families. It's amazing what you learn from those conversations, as painful as they can be. And while in-office satisfaction surveys can be helpful, parents are often in a rush to complete them and are very reluctant, it seems, to write anything critical. So to get more candid, anonymized feedback, we've recently turned to SurveyMonkey. We send requests to a limited number of blindly selected patients seen during the previous month. Returns on those requests have been fairly limited. We figure parents are just too busy. The best feedback of all that we receive is the unsolicited reviews we get on our Facebook page and other social media sites. That's when we know we've hit our mark and that our care is responsive, compassionate, family-centered, accessible, all the things we knew we wanted to provide even before we had the words to name it, a patient-centered medical home.
Wonderful. It seems very resourceful, turning to lots of sources of information for ways to just continuously improve your quality and know if you're hitting the mark. And I especially like what you had to say about the Facebook page. Overall, I wanted to ask, out of the different strategies that you described here, which strategies do you think worked well within your practice, and why do you think they worked well? And as a follow-up to that, were there any dead ends that weren't really necessarily worth the effort to go grab the information or to get the data that you were seeking? So Marian, I'd like to start with you.
Wow. So I think that I would have to say that the strategy that was the most important for us was the collaborative strategy of making sure we had enough collaborators to do this. It makes the work a little less quick because you've got to get everybody together and get their buy-in, but that's definitely, I would recommend that strategy is really important. And that's the thing that was the most helpful. I think developing common communication or standardized communication was another piece that was really important. And again, even at the individual medical home level, where folks could understand having a contact person at their practice, that the local welfare agency could contact them rather than people trying to find each other, having a standardized contact person. Those sorts of things were really, really helpful. I'm trying to think of the things that were more difficult and not necessarily a dead end. I think we initially were doing a lot of things around, can we change state policy? Can we go in there and just get things changed and get processes changed? I'm not saying those things are a dead end or that we don't want to still do that, but I think the approach is to get the program built, do this good work, and then actually be able to show why policy might need to be improved. So I guess if someone else was going to try to do this, I wouldn't say your immediate step is to just go get your state agency to change all its policies, and then everything will be fine out in the regions, because that is actually the slower and more frustrating approach.
Wise words from experience about the importance of actually getting buy-in and collaboration and really doing all you can to facilitate communication. Diane, are there any last big lessons learned about things that really worked well that you say, you should try this, and maybe some other things that are maybe not quite so helpful?
That's a big question, and it really requires some strategic thinking. I believe that for a small medical home like ours, success depends on 100% buy-in from every member of our team. And that requires ongoing communication and relationship building. The culture of a medical home begins here with our team, with our leadership, with our team, and that in turn translates to the kind of care our patients will get. So I would say one of the most important things is to get buy-in from everyone, and that's how you're able to organize a team that says, yes, I'll wear 3 hats in one day, and yes, I'm going to stay an extra hour today so that every phone call is returned. Yes, I'm going to help that mom with the 3 kids who can't possibly manage them all while we're examining the 4th one, the baby. And so I think the team building, the communication, the total buy-in is critical. And I also think for small practices like ours, it's making sure you don't limit yourself to the resources you have. We had, at least I had, a concern at the beginning that we could never achieve what we were setting out to do because we just couldn't afford it in time or in finances. But by reaching out and finding people and programs throughout the country willing to support those of us who are small to create big things is practice altering. Don't give up because you don't have the resources. There are all sorts of initiatives and colleagues, our colleagues across the street and those throughout the country who have been mentors for us.
Wonderful. Thank you so much, Diane and Marion. It really seems that relationship building and doing the hard work of facilitating communication and doing the hard work of getting personal buy-in from your collaborators and your stakeholders is absolutely critical to building the community partnerships, the family partnerships, the systems partnerships and collaboration that we've been talking about today. And thanks also for sharing those very practical tips and kind of pearls that may help others to try and either replicate or build on the type of work that you've been able to do in your own practice settings. The strategies that you've been describing today are both innovative and inspiring, and we really appreciate your time and insights. To the audience, if you'd like to be connected with Diane or Marion or have other technical assistance needs, National Center staff are available to facilitate introductions and to provide tools and resources. On the National Center website, below this recording, you'll see a link to a short evaluation survey for this e-learning series. Since this is our first e-learning series conducted by the National Center, we would greatly appreciate your feedback. This concludes the 2nd episode of Where the Rubber Meets the Road, Conversations about Innovative and Promising Practices in Pediatric Medical Home Implementation. Thank you so much for your participation.